Now for a discussion on the future of patient-centered care, please welcome Stephen Jones, President and CEO of Innova Health Systems, Matt Isles, President and CEO of America's Health Insurance Plans, Arshawn Martin, Senior Vice President of American Academy of Family Physicians, Leah McCormick Howard, Chief Operating Officer of the National Psoriasis Foundation, and joining them on stage is Steve Clemens and Julia Manchester of The Hill.
I'm having fun. Sorry about that. Maybe I gotta turn my phone off here. Thank you all for joining us. Years ago, I guess it was about 20 years ago. Stephen, I'm going to toss you my phone. Michelle, I trust you more.
Good catch. Nice.
Years ago, 20 years ago or so, I was at Microsoft in Seattle and went into this display, and it was what the future of the home was going to look like. And it had things like, what with the equivalent of Apple TV and walls that move. I mean, everything, many things that have just become so normal today, but at the time seemed completely crazy and cosmic. And so I just want to start out, because here we've got, a patient advocacy outfit. We've got family physicians. I'm reminded of Little House on the Prairie, not to knock them. Is my mic not working? Okay. We've got insurance plans, got hospitals. So imagine 20 years from now. What is your world going to look like? Are we going to have hospitals? Are they going to look like they are now? Are insurance plans going to look like they are now? How will the ecosystem that all of you are part of going to be challenged in a way to give us something? So all of you sit in major operations, and I'm just interested, are you like Microsoft and have a vision of a very different world, or are we trapped in a stasis where what you have today is what we'll always have? So let me start with you, Stephen. What will Innova look like 20 years from now?
Innova will look like the hospitals across the country, which will be that largely they will be procedure rooms, so labor delivery and operating rooms. There will be imaging, and there will be the ICU beds and small outlying beds for patients between the ICU and being back home. More of the healthcare will be outside the health system, for sure, outside the physical health system. And if we really get it right, we'll have a coordination of that to where people aren't as lost as they've been historically.
How about that insurance side?
Sure. I mean, it's a really interesting question to ask. I think, right, if you look back 20 years, right, and say, all right, how much have we changed, right? Back 20 years ago, pharmaceutical companies used to own PBMs, right? Today, it's a very different world as we think about vertical integration. If we fast forward 20 years, I think the health insurance plans that we see will be both much more high-tech and much more high-touch, right? They are going to want to make sure that they are engaging with their members, consumers, patients on the front end. I think the area of prevention and wellness will be transformed, and the role of social determinants of health and how we think about meeting consumers, patients where they are in their communities and how they live is going to be very different.
And is that going to be real? I mean, I hear a lot of people bandy about meeting patients where they are and putting them at the center of things, which I know is, our main point of conversation here. But, I've been waiting for it to hit me on the head in a real way. And so, is that just jargon, or are there? Do you really believe we're going to begin moving towards a genuine patient-centric system?
I honestly do believe that we will move that way. If you think about the tools and technology and the ability to leverage data and information to know from a predictive perspective how patient lives and care needs to evolve. What we had 20 years ago, right? I mean, the internet was still a brand new thing, right? I mean,
Right.
we were calling everything, www before we were like, the world is going to be very different 20 years from now, and the technology and tools and data that we have to meet those consumers, patients where they are, I think will be fundamentally different.
Sean?
On Matt and Dr. Jones, I think if you think of the last 20 years being defined by centralization and specialization in medicine, the next 20 years will be the complete opposite. So almost a complete left shift in healthcare. So decentralization, as Dr. Jones talked about,
Right.
and despecialization. And we see a world where complex conditions begin to move back downstream to the primary care level. You have machine learning, AI, all kinds of diffusion of information at the primary care level that will allow care to be decentralized from our traditional idea of healthcare delivery. The second thing, which I think is important, is we're going to see a greater level of co-production of healthcare between physicians and patients, even potentially payers, as Matt just said. But I think the co-production and the engagement of patients in their own healthcare is only going to continue to increase as more information becomes available.
Leah, what is your world of patient advocacy and, again, trying to figure out, what will be the barriers we've removed to kind of get to a more both inclusive, patient-oriented system that's real?
So 20 years from now, the psoriasis and psoriatic arthritis community hopes there's a cure for both of those diseases. And the National Psoriasis Foundation is actively working toward a cure and funding millions of dollars of research every year in order to get there. So, that would be our hope 20 years from now, that people, living with both of these diseases have therapeutic options that will actually cure the disease. But absent that, I think what we would expect to see is a much more personalized and customized experience for the patient. So if you are diagnosed with psoriasis or psoriatic arthritis today, about half of our community isn't treating their disease appropriately. And there's a lot of reasons why, but one of the challenges is that while there are a number of treatment options and they all work very effectively, we don't know which is the right option for each patient. And physicians have to go through a bit of a trial and error process to find that therapy that's going to be the best for them. So the hope would be that as medicine becomes more personalized, that we have those tools, biomarkers and other things, to really cut down that process and get patients on the right treatment right out of the gate.
Thank you for this. I mean, it gives me a good idea of where you want to go. And Stephen, I have had a long experience with Inova. I love Inova, and I think you guys do a great job of engaging community. And I think that, but one of the things I've seen in many hospital groups, and I know you've been at Cleveland Clinic, which probably also falls into the white hat category, but there are black hat hospitals in my views. There are black hat medical centers in the sense that some are very jealous, very greedy about data, not quite sharing. I'm just sort of interested in as we sit here and talk about the future again, what hospitals are in part are great reservoirs of data, great reservoirs of information about what kinds of therapies work, what sorts of maladies we face, and how to come up. And I'm interested in how you see the future and what your strategic dashboard is of getting these equities right as a major healthcare system here. That isn't putting big walls up on data, but is figuring out how to share. Because as I was raising earlier today, I was always caught by this issue in the Joe Biden book about cancer and his son dying from cancer, about their inability to pass electronic records from one cancer center to another. So they were actually taking FaceTime pictures of his records and trying to connect with doctors at MD Anderson or something. So give us a little bit more about your priorities as you see the future of healthcare.
I hope that a lot of what you're talking about is historic, and that people being...
I hope it's historic too, but it's still very much present.
I think you're seeing a trend in the other direction. Certainly we're taking lead on the fact that we made very clear. We'll open any data that we can legally open to anyone who should have access to that. For anyone involved in a patient's care, including their family as their caregivers, to not have access to the full data, to me, is unconscionable. So we'll do everything we can. Having said that, we also have some legal restrictions in place. So HIPAA, a very well-intended law, actually restricts a lot of the things that I suspect that my colleagues here would want to be able to do. And so to find a way that we can legally share data, I will tell you that Inova will take a lead in being willing to do that with anybody who's involved in the patient's care.
Steve, I saw you jump out to that. You wanted to jump on
Yeah,
that?
I think Steve's absolutely right. I mean, that's where we need to go. And I think the trend and the tide is moving in that direction. There are technical challenges still that we need to overcome. I think CMS, HHS, has ONC, right, and Congress too has a big focus on how do we, liberate that data and make sure that patient information can be shared in real time with the right people so that you can make the best healthcare informed decision working with your physician, other participants in the healthcare system. We'll get there. It's not going to take 20 years. It's going to take a few more years, I think, until we get there. But the data privacy issues are real. They need to be overcome. A great example of one of the data privacy problems is with substance use disorder, mental health treatment, not to get too far down in the weeds, 42 CFR Part 2.
Right.
You can't share this information that you know should be shared to benefit patients, and those are the kinds of changes that we need in our healthcare system.
So we're having a kind of, I wouldn't call it a kumbaya. You're all getting along much better than I expected. And I guess I don't want to be facetious here, but I do want to sense, if you get a group of people, if I got together with folks on the hospital and health provision side, the number one thing would come up would be payments, the complexity, how awful it is, we're stuck on tracks we can't get off. And so that creates certain realities. If we're to talk to pharmaceutical firms or those that are investing in there, they say, the big change is the insurance plans are the villain because there are more higher deductibles for people, and people are feeling the impacts in ways that they haven't felt before, that the rest of that the price of drugs really. So depending on who you get together with, the villain changes. And so I'm interested in how we get out of that blame game to some degree and get to something that's more constructive, but yet moves the needle forward in creating an ecosystem where all of the participants are essentially pulling together. And to be honest, it's not happening. I think we're going to have a discussion after this where it's not happening. And so I just want to kind of, violate the kumbaya moment and have you go after each other, and tell me what we can do to really change the ecosystem so that the insurers are looked at as a constructive players, the pharmaceuticals are, the hospitals. I mean, right now I just had an email from the rural hospital folks saying, you don't understand, there's a tremendous problem out there in healthcare coverage in non-urban parts of the country, and the pressures on hospitals are part of that. So I'm going to give you all the power, Leah, and just fix this for us.
Well, the National Psoriasis Foundation thinks this question's actually pretty easy, and really it comes down to putting the patient at the center of everything you do.
Right.
So if you start with that premise that the individual patient, not the patient community, but the individual patient is the center of what we're doing here, it's really easy then to see all the other stakeholders as partners. Mm-hmm. And so that's our approach. I mean, last week we had 5 health insurers sitting at our table and talked with them about how to improve access for our community. I think if you approach the conversation not from the perspective that we're on opposite sides, but that we're working toward the same end, it's really easy to try to then find common ground.
And that meeting went well.
Yeah.
That's great.
Yeah, it did.
Yay, Matt. Score for you. Was he there?
No, he was not.
There you go. Sean?
So that's tough to follow because I agree 100% with that, but I'll take your bait on the villain and kind of props character theory and suggest that we have built a healthcare system that was more focused on everybody being a hero and very few people being a helper, and really engaging with patients and helping them navigate both their health and the healthcare system in a meaningful way. And I think some of that is changing, but I think if we all take on an approach that we are helpers versus heroes, we can better distribute dollars, we can better distribute responsibility, and we can probably begin to create a healthcare system that's a little more efficient from an operations standpoint. But when everybody's the hero, dollars follow the most heroic measures in our current system, and we are where we are.
Matt?
Sure. So I'll say, one positive thing and then one, sort of just, I think, elephant in the room that we need to talk about. So on a positive side, I think the movement towards value-based arrangements, shared risk, shared savings, aligned incentives is really helpful. And that's taking us in the right direction. Can we go more quickly? Absolutely. But we're making some pretty good progress. I think the biggest challenge that we face as a country down at a patient level for businesses, for taxpayers, is just affordability, right? It is the biggest complaint about our healthcare system. Doesn't matter whether you're talking to Republicans, Democrats, Independents, affordability of the system and then how that translates into their individual affordability is a problem. And that's ultimately what we need to tackle because we're spending too much. And unless we can really grapple with those issues, right, there's a markup that's going to be happening, in the Senate, some very positive things, some things that we're not so sure about whether it will actually make things more affordable, right? But at least we're starting to have the conversation and moving sort of beyond coverage. We still need to talk about coverage. How do we expand Medicaid? How do we expand coverage to the 30 million Americans who don't have it? Because for them, healthcare is entirely unaffordable. But I think that's really what we need to grapple
Before I
with.
jump to Stephen to answer this, I'm going to just go down one more step with you, Matt. I, at an Innova day-long forum, policy forum that I did some years ago, I interviewed Sanjay Gupta, and he tells the interesting story of his uncle, who was a healthy guy, physically fit, exercising, very aware of his health, and then he got to a point where Medicare kicked in, and he just let himself go to pot, and he died shortly after. He ended up just, going, like, there was something in his mind that if he could just stay okay until the point at which others were taking care of his health, and then he went there, and it's always, been on my mind as far as incentives. So as people have moved towards higher deductibles, as we've seen the Affordable Care Act come in, but it's sort of changed the financial equation. As people are paying more, have you studied the impacts on their awareness of their health? We had a question earlier about wellness and prevention, and I'm just sort of always interested, if people have more skin in the game, more dollars in the game, is there a net benefit? Could a positive side of this rise in costs be that people are more aware of their health and clicking in a different direction, or is that a fantasy of mine? No, well, you're going to answer for Matt.
Well, I'll answer for Matt. So the fight to me is we became too premium sensitive in and around the ACA. We emphasized premium cost, kind of lost track of out-of-pocket and costs to the consumer. I think the data goes in the opposite direction. I think people are becoming more aware of the economic constraints on the access to the healthcare system, not their own health status. So I think Commonwealth had a study that
so it's the opposite.
So almost 40% of people said that they are foregoing X because of the financial constraints that they face in accessing the healthcare system. And so I think they have become price sensitive in a different way, not health sensitive.
Matt? Yeah, I think the challenge is you have to think about who's paying for healthcare, right? And still, by and large, in this country, employers are paying a huge amount for a large share of the population, 180 million people who have employer-sponsored coverage. Right? They're looking at how much can they afford. They want to provide generous benefits. They want to provide comprehensive benefits, but they also are mindful about how costs have increased and where is that balance between having an affordable premium and option that they want to offer to their employees, and then what can they afford, versus giving sort of everything under the sun. And the trade-offs are premiums and cost sharing. Right? There's only so many levers. We want people to be more healthy. We want people to be more aware of what items cost, and that's why there's a huge movement towards transparency, making sure people know, right, if they go to one place versus another, one physician versus another, what are the costs and hopefully quality trade-offs.
The challenge is that if you're someone living with a chronic disease, there's only so much you can do to reduce those costs. So while we spend a lot of time talking about thinking about your healthcare beyond premiums, we know that the cost shifting that's happened for patients for their therapies to more and more copays and out-of-pocket costs has really challenged people with staying on therapy, which ultimately is going to cost the system in the long run.
Stephen, I'm going to leave you with the same issue of how you'd like to see a disruption among some of the other stakeholders.
Healthcare is not a real market, and I think that's what you're alluding to here, is
Right.
that it's never clear who's going to pay it. High deductibles obviously have had a significant influence in some potentially good and potentially bad ways, actually, and no one's yet, I think, come to an assessment on what that really means. What gets lost in this discussion is a couple things. One is, it's really not about price. Everybody keeps talking price. The least expensive healthcare is healthcare that wasn't necessary, that didn't get delivered, and that gets lost in almost all the discussions we have down this line. And the other part is the amount of cost that ultimately leads to price that has zero value add, and that when you look in all of our industries, there's no doubt that there are tons of pieces in the provider and in the insurer and every one of our industries, a massive amount of cost that goes in that many other countries don't have that cost built in, so it doesn't end up in their price, and that the simpler that we make our healthcare overall and take out those non-value adds, there's a massive amount of savings to be had there that we haven't been able to tackle, potentially because we haven't worked together on it fairly.
Before I go to the audience, Stephen, let me ask you one last question, and everybody feel free to chime in. One of my former colleagues at The Atlantic, Olga Kazan, wrote this fantastic story about a young woman in Baltimore and tracked her, and she was an African-American and just a real bright light, but it was a sort of chronicle of how the system was stacked against her and her family, despite her extraordinary abilities. And I learned a lot about the difference in zip codes, that what zip code you're in had enormous correlation with your life expectancy, and you could have 20-year differences in life expectancies across different districts. I'm really interested in how, I can't believe in America that that's the case, but it is the case. How can, in this case, we had a lot of folks from Johns Hopkins at this and many people, introspectively said, we're not doing enough at Johns Hopkins to work with Baltimore, that we've allowed this wall that we need to take down. We need to find new pathways in. The new head of Planned Parenthood, Lena Wong, I think, was the head of health services in Baltimore and was trying to do things. And I'm interested in just your perspective about how that needle into districts and cities and urban areas or rural areas that we're not able to reach today. But Stephen?
I think it's been pretty clearly defined that only 10 to 20% of all the health outcomes actually relate to health care. So 80 to 90% is unrelated. And when you talk in terms of zip code, I don't think it's usually that you don't have access. I suspect that those folks have access to the hospital nearby in that example, Hopkins. But there are a number of other factors against those folks from the minute, before they were born, that are way more greater multiples on the actual health outcomes that they're experiencing.
Thoughts, gentlemen?
Yeah, I'll jump. That is a huge priority for our membership. We just came back from our biggest conference in Nashville, and it was the topic about how do we address these issues around social determinants of health. AHIP's launching a big initiative called Project Link to really figure out how can we get to people in their community, share best practices, focusing on nutrition, transportation, health literacy, other access programs, housing, all right, the things that we know have a huge impact. And I'll say one of the bright spots to look at least around health insurance providers, is really what's happening in Medicaid managed care. I mean, they are operating on razor-thin margins, and they know if they can make a difference where people live, that they can not only improve health, but do better for the entire system.
Sean Lee, a quick comment?
Yeah, so quickly, we too are investing heavily in this, called the Everyone Project. I think the 3 items of housing security, food security, health security are huge. Agree with all the statistics, but I think this is one place where you could see enormous collaboration. I'm really looking forward to what AHIP is doing and how community level physicians can engage in that effort.
And I'll just say, in certain parts of the country, there are real access issues. I mean, there are parts of the country where to find a rheumatologist or a dermatologist, you're driving hours. So I think that is a place where things like innovation, teledermatology, and other new technologies will make it possible for people to overcome access barriers and be able to engage with the specialists that they really need to be talking to.
Thank you very much. And now just put a marker down. I really want to see more of what the AHIP folks are doing. So if you bring some of that online, look at some of the solutions, it would be great. Okay, great. It'd be fun to do it. Let me open the floor to questions and comments here. Let's go to the very back. Like that Neil Diamond. Nobody remembers Neil Diamond anymore. Hot August night in the back. I'm old. I always like the folks in the back row. Yes.
Hi.
Hi.
My question is for Dr. Jones.
Yes.
I'm very much interested in the consolidation that seems to be happening in Northern Virginia right now. Inova seems to be very aggressive about purchasing the smaller practices, and I'm wondering what Inova is doing to sort of protect the community and make sure that we don't fall into the same trap of prices, competition coming down and prices going up, and also how are we going to make sure that all of our services are available to the Northern Virginia community? I mean, you have a huge market share in Northern Virginia right now, and if you start to cut out things,
So what's your business plan? What are you going to cut? What are you going to keep? And who are you going to buy?
Yeah, we've been very transparent. Is that we actually have made very clear our goal is not to employ physicians. Our goal is to partner with physicians in a meaningful, sustainable, enduring way towards the better care of our patients, and that some physicians choose to be employed. There's no doubt that that is a trend nationwide. It didn't start in Northern Virginia, and in fact, it's actually way behind the rest of the country in Northern Virginia compared to most markets. So we do want to be partners with physicians. We want to be able to have connectivity. We want connectivity on the IT side because of the issues that we addressed earlier, but we absolutely don't have a goal to employ all the physicians in Northern Virginia, quite the contrary. And we do have a large market share on the inpatient basis, which has been pretty stable for several years. So there actually hasn't been a change in that recently. But truly partnering with the physicians is really a goal of ours. There's no doubt about that.
Sean, do you have a view on that?
I think partnership is critically important, whether it be an urban area or any other part of the country. I think consolidation is bad. I mean, consolidation of the ambulatory community-based physician community into kind of vertical integrated systems is probably not going to serve the country well.
Other questions? I saw other hands. Yes, right here in the back over here. Right, yeah. Wherever you're going to go is fine, okay. Thank you. Hi.
Hi, I'm Christy Munger. As a recent cancer survivor, Dr. Abernathy's comment about precision medicine aligning to who a patient truly is really resonated with me. So I'm curious how the panelists are incorporating things like patient preference and patient-reported outcomes to improve precision medicine and quality of care.
Thank you. Leah, let me start with you with that.
Yeah, I mean, this is a critical issue for the patient community, and the NPF has really been pleased to do a lot in this space. We had a patient-focused drug development meeting back in 2016, and I think have talked a lot about kind of the importance of understanding the patient community. I think one of the things that's really critical, to your point, is recognizing that even when you do that discovery and kind of understand what patients are looking for, that's kind of community-wide information. And at the end of the day, what really matters is kind of the individual patient sitting there looking at you. So, I think the more we can have patients at the table and be hearing from patients only leads to good things, but still we need to do the advancements in science so that we can make treatment decisions relative to that particular patient, not the patient community in general.
Other thoughts real quickly on that front?
Sure, I'll jump in. I think, as health insurance providers are evolving to really try and meet patients where they're trying to evolve from not a one-size-fits-all, but like what size fits you, knowing that you're an individual. There's more work for insurers to do in that regard, but I think that there has been a significant change in terms of how they think about engaging with people, no matter what their health condition is, recognizing getting the best health outcome for you is probably also the best economic outcome for the system. So it's an evolution, but I know that things are headed in the right direction, but more work needs to be done.
Just in the last 30 seconds each, Stephen and Sean, in this question about personalized medicine and precision medicine and the information and what insurance companies know, you have to have a lot of trust in that system that it's not going to come back and bite you sometime. You have to trust that you're not in China to some degree, that information that's out there on one hand won't be used against you in another quarter, as we see happening in China today. And just in your two final comments, and we'll just wrap this up, how do you, what steps would each of you take, maybe this is an unfair question, would you take to establish trust in institutions? Because honestly, the kind of world you just talked about, I don't think that's going in the right direction. I think trust is going in the wrong direction. So what do you do? Let's give you two the last words.
So I would go back to my comments on hero versus helper. I think physicians, this might get me fired, I think physicians we need less of a physician-centric delivery system, and we need physicians to be engaged in the co-production of healthcare with the other person in the room. And that is a complete mind shift through our education process and how we view physicians as a society.
Stephen?
Even though you use the term black hat, think that realistically, the industry is known for trust, and that people entrust us with their most private information. And I think we actually have, as an industry, a pretty good track record on that. What makes all of us probably lay awake every night is the concern of the things that we can't control, whether it be a bad actor or just an accidental data breach in which suddenly we don't have the ability to control it. But we all spend, I bet between all of our organizations, spending a massive amount on trying to secure those data in a way that assure that we don't belie that trust.
Well, I just consider you one of the white hat guys, just so you know. But let me thank Stephen Jones, President and CEO of Inova, Matt Iles, President and CEO of America's Health Insurance Plans, Sean Martin of the American Association of Family Physicians who may be looking for a job, and Leah Howard of the National Psoriasis Foundation. Thank you all so much.